What is up, everyone? Welcome back to the channel. I thankfully got the day off. The attending I'm working with unfortunately broke his ankle, so he asked that I not come in today so he could kind of figure out the workflow of hobbling around the office by himself. So I was like, you know what, not gonna fight that. I have plenty of studying to do because FM has so much content. So just had a nice morning, went to an area that I really haven't been to go to a coffee shop, and it was awesome. It's like such a beautiful day, and the coffee shop, I didn't know this, but has like a huge outdoor area. So I sat inside for a little while, did some Anki, then went and sat outside to just enjoy the weather. But in today's video, I want to talk about sort of family medicine in general, because I really haven't touched on like what family medicine is, what is it like working in an FM clinic. Last video I kind of touched on the fact that you can practice both inpatient and outpatient as a family medicine doctor and talked about the differences. But in terms of more generally what family medicine is, honestly, I would consider it the most like general specialty that you can do. Most family medicine physicians end up going into primary care. There's sort of three main pathways to primary care. That would be family medicine, internal medicine, and then pediatrics. Some people will consider OBGYNs a form of primary care, but generally those are like the three fields that feed into primary care in some way. But with those three fields, pediatrics, obviously you're only going to be treating children. Internal medicine, you're really only trained in adult medicine, but for family medicine, you're really trained from cradle to grave. So you can see pediatrics as part of your residency training. You can see adults, you can see geriatrics. You have training in OBGYN, so you can see pregnant patients. So in terms of that, I feel like it's really the most general specialty. Unfortunately, primary care kind of gets a bad rap. It is a pretty tough job. It's not exclusive to this field, but there's a lot of, trying to navigate around insurances. With being a primary care physician, you're kind of supposed to touch on everything. You're supposed to coordinate care, all of the patient's ailments. So if someone has a whole list of medications and a list of diseases, it can be really burdensome. And unfortunately, they're really not compensated the way that they should be. However, it is, getting better. We know that we have a shortage of primary care physicians, and in the recent years, the compensation has gone up. So in 2022, primary care providers saw average increase in their salary in 6.1%, which is a lot more compared to all of the non-primary care specialties, which was 1.5%. So at least that is showing that there is, an emphasis on increasing compensation for primary care, because it's going to incentivize people to go into it. With how expensive medical school is, some people come out with $400,000 or $500,000 in debt. And when you're looking at the salaries for different specialties, picking something that pays half as much as something else isn't really a good financial decision if you're worried about paying off your loans. But back to sort of the main point of the video and talking about the variety of things that you treat as a family medicine physician. It really is like the jack of all trades specialty. Obviously, you have the primary care aspect, which is mostly focused on preventive medicine. So making sure the patient is getting all the right vaccines, having all the right cancer screenings, blood work to spike cholesterol, making sure you're screening for diabetes and hypertension, all that really important preventive stuff. But also, as I mentioned, can be a pediatrician, you can treat kids. Same thing, you get the training in obstetrics and gynecology, so you can have that as a pretty big part of your practice once you come out of residency. There's a lot of diabetes management, so you act as an endocrinologist. You'll manage hypertension, hyperlipidemia, so you're a cardiologist. A lot of people will come with dermatology issues, different rashes or moles that have the ability to biopsy things and, have that first line treatment. For dermatologists, obviously, if something comes back as cancerous or something that you really can't handle or don't know, you will still have sort of your network of people to refer to. For a lot of the simple things, the family medicine physician can handle everything. Also, orthopedic injuries, back pain is one of the most common things people will go to their doctors for. So having that training where you know what to do for low back pain, the right physical therapist to refer them to. You can do joint injections, and honestly, the biggest way to get into non-operative sports medicine is through a family medicine residency. And then also, family medicine physicians do a lot of managing psychiatric illnesses like anxiety and depression. There's also a shortage of those providers. So a lot of the times the first line treatment can be initiated by a family medicine, primary care doctor. And then if things get a little bit too complicated, then, you can refer them to a psychiatrist. But yeah, I mean, over my 6 weeks in family medicine, I've been enjoying the variety. Obviously if you have a day that's pretty much all annual physicals, it can get old, but once you have these different things sprinkled in there, it really makes the day go by faster and keeps things a lot more interesting. All right, so it's Thursday. I just got done with clinic, and I want to talk about the just crazy variety of patients that I was able to see in just one day on Family Med. So obviously I had some just like yearly physicals, which are generally pretty easy, especially if the patient is feeling well. They don't really have any complaints. You basically just, go over the medical conditions, whatever medicines they're on, ask about lifestyle stuff, diet, exercise, alcohol, tobacco use, talk a little bit about their work life, home life, that kind of stuff. And then the biggest part of yearly physicals, especially once patients get older, making sure they're up to date on their screening. So for patients who smoke, you need to know the guidelines of lung cancer screening. Once patients get a certain age, they need to start getting colon cancer screening. And then also making sure patients are up to date on whatever vaccines that, they should be getting. So had a few of those, then had some other pretty interesting patients. So there's this one patient who was coming to us for headaches. She did have a history of migraines when she was a kid and a family history of migraines as well. So all in all, we kind of chalked it up to it being migraines. But the interesting thing about this patient, when the medical assistant came and sort of told me and the attending what was going on with the patient, she mentioned this tremor that I was trying to think, like, oh, that's pretty interesting, like headaches and tremors, like maybe it's something else going on than just like normal migraines, normal headaches, that kind of stuff. But then when I was looking through the patient's chart, saw that they have schizoaffective disorder, which is a personality disorder which is treated sometimes with antipsychotic medications, which sort of block dopamine receptors. So one of the biggest side effects with those kind of medications is a drug-induced Parkinson's disease almost, because the whole issue with Parkinson's is you don't have enough dopamine. So if you're taking a medication that blocks dopamine, you could have similar side effects. So kind of chalked up her mild tremor to that, probably because she had been on that medication for a while. So that was just like something that I would always read about in textbooks is, drug-induced Parkinsonism secondary to an antipsychotic. Just pretty cool to see it in real life because that was kind of the first time. Then another patient was like a pretty classic presentation of subacute thyroiditis, which is a condition where usually after you have some sort of virus, for whatever reason, your thyroid gets attacked. And, the patient came in with the classic hyperthyroid symptoms of weight loss, tremors, feeling hot, feeling palpitations. So we asked if she had recently been sick. Sure enough, she had some sort of cold a few weeks ago. So did her husband. When we were doing the physical exam, her thyroid was diffusely tender. She didn't have any trouble swallowing or anything like that. So once again, that was another thing that I'd seen so many times throughout, even preclinical in question stems, but it was first time seeing it in person. So then also saw some other pretty common things, like saw a patient with gout. They had a history of gout, so they kind of knew what was happening. They just, needed some help for like sort of a rescue medication. But once again, first time seeing gout. And then had a patient who had a history of asthma so all in all, pretty good day. Really just shows like the wide variety of things that you see in family medicine. There was also some other patients, one with a rash, one with like some low back pain. So you're really just seeing a little bit of every field as an FM doctor. All right, so I just finished up my 6th week of my family medicine rotation, and the last thing I wanted to touch on in terms of what it's like being is the continuity of care. You know, different fields of medicine have varying degrees of continuity. You know, you think about something like emergency medicine or anesthesia, you basically get no continuity. You know, there's always the people in the ER that are frequent flyers, but other than that, you're not really going to be seeing patients again and again and again. Same thing with anesthesia. You'll put them to sleep for the procedure, probably never see them again. You know, there's some fields that get a little more of it. Certain surgical specialties, even if you do one procedure on someone, maybe they'll come back for, follow-ups or different kinds of procedures that same surgeon can still do. You think of stuff like dermatology, where you will maybe take care of someone for 20, 30 years and, see their family and stuff. So you get a lot of continuity there. But honestly, I think that family medicine has the most unique and greatest amount of continuity of care. As I mentioned in my last video, I kind of talked about the differences between inpatient and outpatient, the fact that, as a family medicine physician, you can practice in both of those settings. So that's sort of one way that the continuity comes in, where we'll have these situations, and I've, talked to the residents about this, where they'll care for a patient in the hospital, so they'll see them from the admission in the ER all the way to discharge, and then as a part of their discharge plan, it's like, hey, you need to follow up with us in our outpatient clinic next week. So then they'll be able to see them in the clinic as well, and there's sort of that continuity between the hospital setting and the outpatient setting. So that's really cool. And as I mentioned, you can get situations like that as a surgeon, where someone will come in, be admitted to the hospital, you do surgery on them, and then you'll need to follow up after. But the other way that family medicine is so unique in the continuity is just because of going back to the scope of practice. As I mentioned earlier, you can see people in a primary care setting, you can see them in an OBGYN setting, and then you can also see children in pediatric setting. So we actually had a small group session on Wednesday of this week, not really related to clerkships at all, but we always have a short check-in, people talking about their experiences on clerkships, how they're doing. And one of the students was also on family medicine, was talking about how she really likes her experience on family because of that continuity, and it's something that not a lot of specialties can experience, because she was saying how, at the beginning of her rotation, they were seeing this one patient who was very pregnant, 37, 38 weeks pregnant. So they were coming in pretty often. She had seen her a couple times, and then she finally had her kid. She wasn't able to go to the delivery. It was midnight on a Saturday, but, the resident that was seeing her in the clinic was called to go deliver the baby. So even that is just, such a great opportunity, stuff that OBGYNs would experience all the time. But sort of the unique part of being FM is now this patient who just gave birth, this new baby, can come back the next week and see the same physician, one, for themselves, make sure they're doing okay, and also this can now be the baby's healthcare provider. They can act, in that pediatrician setting, so they're having newborn visits, and now, they can see that same doctor until they retire. So while I haven't experienced that in my practice, my attending doesn't really see a lot of OBGYN patients or pediatric patients, and it certainly depends on the area of the country that you are in, or kind of just your desire to do that as a family medicine physician. But the big thing is that is just totally in their scope of practice and part of their training and residency. So it's just leaving all those doors open. All right, well, that is going to do it for today's video. If you enjoyed, please be sure to leave a like below and subscribe if you want to see videos like this in the future. Thanks, and I'll see you in the next one.